Acute pancreatitis is a sudden, severe inflammation of the pancreas that occurs when digestive enzymes activate prematurely inside the pancreas, causing it to digest itself. In normal pancreatic physiology, inactive pancreatic enzymes are secreted through the pancreatic duct into the duodenum. Within the duodenum, the enzyme enterokinase, located on the intestinal brush border, activates trypsinogen into its active form, trypsin. Trypsin then activates the remaining pancreatic enzymes, initiating the digestion process. Let's discuss the pathogenesis of acute pancreatitis. This condition occurs when digestive enzymes are prematurely activated within the pancreas itself rather than the duodenum. These active enzymes begin digesting the surrounding pancreatic tissue in a process known as autodigestion, which triggers severe inflammation. Generally, the causes of acute pancreatitis are divided into obstructive and non-obstructive groups. Obstruction of the pancreatic duct increases intraductal pressure and induces local ischemia, leading to acinar cell dysfunction, which triggers the premature intracellular activation of trypsinogen and other digestive enzymes. For example, gallstones and tumors can obstruct the duct and initiate acute pancreatitis. The non-obstructive group involves causes with direct toxic injury to the pancreatic cells, causing them to release pancreatic enzymes and activating them. Examples include direct trauma to the pancreas, certain drugs such as sulfa drugs, reverse transcriptase inhibitors, and protease inhibitors. Infections like mumps, alcohol, steroids, scorpion stings, hypercalcemia, and hypertriglyceridemia. In fact, the most common causes of acute pancreatitis are alcohol and gallstones, which together account for 80% of cases. To diagnose acute pancreatitis, two of the following three criteria must be present: epigastric abdominal pain, elevated pancreatic enzymes, and characteristic imaging findings. The abdominal pain classically radiates to the back due to the retroperitoneal position of the pancreas. Serum amylase and lipase levels should be at least 3 times the upper limit of normal, with lipase being more specific to the pancreas. Finally, imaging such as a CT scan may show characteristic abnormalities like pancreatic swelling and peripancreatic edema. For example, if a patient presents with sudden severe epigastric pain radiating to the back and a serum lipase level exceeding 3 times the upper limit of normal, a diagnosis of acute pancreatitis is confirmed. Similarly, if a patient presents with the classic epigastric pain and an abnormal pancreatic CT scan, these two findings alone are sufficient to establish the diagnosis. Taking a patient history helps identify the underlying cause of the inflammation. For example, a history of heavy alcohol use points to alcohol as the primary etiology. Similarly, a history of gallstones suggests a stone may have migrated and obstructed the pancreatic duct. Many other potential causes can also be identified through a detailed patient interview. The treatment of acute pancreatitis focuses on supportive care, using analgesics for severe abdominal pain and intravenous fluids to maintain blood pressure and prevent organ failure. To prevent pancreatic stimulation and enzyme secretion, oral food is temporarily withheld until the acute phase resolves. Let's discuss the complications of acute pancreatitis. While the condition normally resolves spontaneously, severe cases can progress to life-threatening complications. Initial complications include hemorrhage and shock, which arise from enzymatic vascular damage and subsequent blood leakage into the peripancreatic space. Ultimately, this profound shock can trigger multi-organ failure. Fat digestion around the pancreas by released lipase leads to fat necrosis. This process releases free fatty acids that bind to serum calcium ions in a mechanism known as saponification, which can precipitate hypocalcemia. Another significant complication is acidosis, which is lined by granulation tissue and fibrosis rather than the epithelial lining found in a true cyst. If a pseudocyst becomes infected, typically by enteric bacteria like E. coli, it can progress to an infected fluid collection or abscess. The extension of necrosis and hemorrhage into the retroperitoneum and periumbilical soft tissues manifests clinically as Collins sign in the periumbilical region and Gray Turner sign in the flanks. Acute respiratory distress syndrome (ARDS) is induced by the circulating pancreatic enzyme phospholipase A2, which degrades alveolar surfactant and damages the pulmonary endothelium. Concurrently, the systemic presence of these proteolytic enzymes triggers widespread activation of the clotting cascade. This can precipitate disseminated intravascular coagulation (DIC), which paradoxically manifests as both microvascular thrombosis and severe bleeding.